Have you ever wondered what the actual criteria for dementia is? What the doctors are looking at to make that diagnosis? I'm going to go over that with you today, and you can take a look at the 4 major criteria and see how your loved one scores on those 4 major criteria. Also, it's pretty interesting to note that most medical conditions are diagnosed based on some sort of lab results or some sort of clinical finding through testing. Diabetes, they're going to look at blood sugar. High blood pressure, they're going to look at the number on the high blood pressure. And so regardless of the actual words the person is saying, like sometimes I get shaky after I don't eat, or sometimes my heart beats fast, while that information is helpful for the healthcare providers, the diagnosis is largely coming after they've looked at the lab results, after they've looked at the pathology. And even though in the world of dementia, there's been lots of breakthroughs and progress in terms of biomarkers and pathology, right now, the diagnosis of any type of dementia is really coming largely from the clinical manifestation. It's one of the few conditions that's still diagnosed largely based on how the person is looking, how they're acting, what the family members are saying. Let's dive into what the Diagnostic and Statistical Manual of Mental Disorders says about dementia. That's a mouthful. We'll call it the DSM for short. Technically speaking, there are 2 major classification resources that are used to give diagnoses of any type. One is the DSM, Diagnostic and Statistical Manual of Mental Disorders. Yes, dementia is considered under the category of mental disorders. And then there's also something called the International Classification of Diseases, the ICD. And dementia is under the mental disorder category in that book as well. But for purposes of this video, we will go over what the criteria is in the DSM. And one caveat real quick is that the DSM is not a finished product. It's not something that once it's there, it's done. As you can see, we're on the 5th version right now. There's been 2 versions since I've been in practice, and we don't always get it right. And it's always changing based on what research is showing. In fact, here's a photo of some old DSMs. In the past, as an example, homosexuality was listed in the DSM as a mental disorder. Obviously, that's not the case anymore. As research comes, as times change, as thinking evolves, what's considered a diagnosis in here changes. And so keep that in mind. I'm giving you here at November 2023, I'm showing you what the diagnosis of dementia is now. Will it change? Absolutely. Okay, so there's 4 major criteria. The first criteria that has to be met is that there has to be a significant decline in a previous level of cognitive functioning. So meaning if somebody has always had impaired memory all their life and it doesn't represent a decline, it does not count. It has to be a decline from some sort of previous level. And the way that decline is determined is 2 different ways, and both have to be shown. One is that a person has to say there's been decline. This can be the actual person, the patient, the person who's noticing changes in their thinking. They're bringing up to the doctor, hey, I think something's off, something's not right. It could be the doctor or healthcare provider who's familiar with the person saying something is changing, something doesn't seem right. Or it could be, which is most often the case, a family member or loved one saying, hey, I'm noticing changes with my loved one that don't seem right. So that's the first criteria here that has to be proven that there's been a significant decline. The second thing that also has to be proven is that we can't just take people's word for it. We actually have to have evidence that there's been decline or that there is impairment, and that's going to be based on an assessment. Preferably a standardized neuropsychological assessment, which is typically a several-hour procedure with a neuropsychologist and is not a 30-question questionnaire given by any primary care doctor, nurse, or neurologist. It's usually more in-depth testing. And that's going to be preferably when it's available, when it's possible. There's not a lot of specialists. There's wait times are a long time. So there's things like that get in the way. But this is the first criteria that has to be met. Now, the second criteria that has to be met is that it has to interfere with daily activities. It has to be a significant level of interference in daily activities, at least in complex instrumental activities of daily living. So daily activities of living are grouped into 2 categories, instrumental and basic. Instrumental will include things like paying bills, managing finances, driving a car, cooking food, and basic would be toileting, eating, grooming, those dressing, basic things like that. So far, if your loved one has a diagnosis of some type of dementia, do they meet these two criteria so far? Either significant decline in thinking from a previous level of functioning, both noticed by an individual and based on testing or some sort of assessment of numbers, and then 2, that it interferes with their daily activities. Yes? No? Do you notice that? Okay, those are the 2 biggies. The next 2, basically, is that none of the problems can be a result of delirium. Delirium is a medical condition that requires immediate medical attention. It is often reversible, treatable, improvable. People with dementia can have delirium. People without dementia can have delirium. I can have delirium. If I were to have a delirium, I would probably look like I had dementia with not being able to remember things and not being able to do things, but I wouldn't have dementia because I had delirium. So we always have to make sure we rule this out. Now, somebody who had dementia and then delirium on top of it, they're going to look much, much worse than they actually are. And when the delirium is cleared, they tend to look better, but they would still have dementia. So we just have to make sure none of the thinking problems and functioning problems are a result of this. And then finally, we have to make sure that it's not due to another condition. We've talked a lot about on this channel that any diagnosis of any type of dementia cannot be better explained by another medical condition, meaning that dementia is a diagnosis of exclusion. So before anybody gets a diagnosis of dementia, they've excluded everything out, which is why we never jump to the conclusion when an older adult has memory problems. People want to say, oh, maybe it's dementia. No, we have to rule everything else out because there are a lot of look-alike conditions that look like dementia that aren't. So we want to do whatever we can to get rid of those or to treat those or to help those improve. Whenever we're talking about dementia, ideally, what is supposed to happen whenever we can is we need to specify what's causing those problems. Dementia is a condition. It's not the actual diagnosis, even though we talk about it that way. There's specific types of dementia. And so according to the DSM, they want the provider to diagnose, which is it? Is it due to Alzheimer's disease, frontotemporal, Lewy body, vascular, traumatic brain injury, substance or medication use, HIV infection, prion disease, Parkinson's disease, Huntington disease, another medical condition, multiple etiologies, meaning a combination of any of these, or unspecified, meaning they really don't know. Maybe they would know in time with future testing or just future observation, but that's ideal. Do you know what specific type of dementia your loved one has? If not, it's unspecified. If so, it's probably one of these. And interestingly, if you noticed, if we go back to this is the actual DSM, if we go back to the actual category of what dementia is, do you know what's not on here in order to have a diagnosis? There's no requirement to have any brain testing, meaning brain scans, imaging, MRI, CT scan, things like that. That is helpful in being able to determine the type, but it's not a requirement. It's not something that has to happen in order to meet the criteria for dementia. Can it be absolutely helpful and give more details to the clinical picture? Yes, but certainly not a requirement. Do you want to know how this differs from mild cognitive impairment? Let's pull up the criteria for mild cognitive impairment real quick. So this is the mild cognitive impairment. There's 2 differences. So to start, the last 2 are exactly the same. Cannot be during a delirium, and it cannot be explained by another condition. So those are the 2 right here. Like cannot be explained by anything else, cannot be due to a delirium. These 2 are where it changes. So evidence of modest cognitive decline from a previous level of functioning. The difference here is the word modest. In the major neurocognitive example and the dementia example, it was actually significant cognitive decline. In mild cognitive impairment, it's a modest cognitive decline. So in mild cognitive impairment, there's modest cognitive decline. If you would like a future video on how does the healthcare provider know the difference between modest and significant, let me know. I can do a video on that. And the other big difference is that the cognitive deficits do not interfere with the capacity for independence living and everyday functioning. It could require the person to take extra time, extra thinking, extra effort, but it doesn't interfere. So here, for instance, it says the cognitive deficits do not interfere with capacity for independence and everyday activities, such as complex instrumental activities of daily living, such as paying bills, managing medications. They're preserved, but greater effort, compensatory strategies, or accommodation may be required. Compensatory strategies are just strategies somebody uses to help compensate. So maybe before, when they would make some of their favorite recipes, they might glance at the recipe from time to time, but they are able to cook and remember a couple of steps. Now, when they're cooking, they have to look at each step and then do the step, and maybe they have to reference it again before they continue. That's how they're compensating. So technically, they're still able to make that meal. It's just requiring greater effort from them. So it technically does not meet this criteria. They're still able to do it. The same thing might be true if they're managing finances and maybe they need to take more notes, or they need to reference their checkbook more often, or keep a detailed log of when they paid, what they paid, check mark that they paid it. And before, they didn't really need to do all of that. They're still paying their bills. It's just requiring some extra effort. So it does not meet the criteria of significant impairment. So they would fall under the mild cognitive impairment category. What are your questions there? Any questions in terms of diagnosis for actual dementia or mild cognitive impairment, or what the heck the difference is between modest and significant cognitive impairment? 2 words, just like one word switched in between that diagnostic criteria, but it actually makes a world of difference when it comes to the true diagnosis. Careblazer, I hope one day that the diagnosis of any type of dementia is much simpler, easier, doesn't require hours of cognitive testing. But right now, this is what we have. And so no wonder there's lots of confusion and lots of questions. I hope this helps clear things up for you. Sending you love. Bye.
Also, Nico gets a belly rub for every person who subscribes from this video. So if you haven't already, click the red subscribe button. It's totally free, and Nico says thank you very much.